Welcome to Double Blind, discussions and games that provide real-time, thought-provoking conversations. We're your hosts, Ariana Pelosi
and Pat Pastor.
Now, before we jump into the most iconic clinical trials and top conferences of the last year, our guest today is an up-and-coming leader in gastrointestinal oncology, the 2024 ASCO Young Investigator Award winner with a focus in translational sciences, AI, computational biology, alongside GI malignancies. We welcome Dr. Nicholas Hornstein.
Hey guys, thanks for having me. I'm excited to be here.
Thanks so much for joining us.
So I hear we have some games in store.
Yes.
What do we have first?
Well, before we kick off, we know you've lived on both the East Coast and the West Coast, so we were wondering which one has the better food.
Okay, that's a really challenging question. I don't believe in such a thing as better food. There's different food, right? So I will say when I fly back to Los Angeles, I probably gain a few pounds. That's where I grew up. That's where I know like all the spots that are local to me in a way. But I don't know. I went to medical school on the East Coast, spent 10 years in New York. I think for fancier fare, a little more frou-frou, I'm going to move towards New York, Manhattan. But in general, I think the food is better in California. Don't tell anyone.
Okay.
That's a hot take right there.
I know.
We're talking about editing things. We might have to edit this for the East Coast audience. What's the best food, or what was the West Coast food known for and East Coast? I was going to ask you about pizza, but I feel like that's a no-brainer.
Yeah, I mean, like, look, if you're going to have pizza, you go to New York. What is it, Le Industries, like the new hotspot. I walked by there the other day down in the Village. There's 200 people standing outside in line. Why would you wait that line long for anything?
It's a trend on social media.
Yep.
Okay, that's why. There we go. Specific things, I don't know. I think more ethnic cuisine, maybe a little bit better in New York, especially if you're going out into Queens, the Bronx, outer boroughs. But LA in general, I just think like the level of quality is maybe a little bit higher.
Yeah.
Don't quote me on that.
The food truck industry I hear on the West Coast is like the food truck scene, I should say.
The food truck scene was pretty wild. I was there for residency. I was at UCLA, and like I don't know, 30% of my meals were from food trucks. Maybe that's because I was a resident and I had no time and money, but it was pretty good.
Yeah, and they're getting a lot of these like Michelin star chefs creating their own food trucks and traveling around, which I think is really interesting.
Yeah, well, look, you're a Michelin chef, you're working crazy hours, you're dealing with kitchens, maybe you're like in a scene of The Bear, you realize your life isn't what you want it to be, and hey, now I can go have a food truck.
That's right.
Right?
Yeah,
so
make your own hours.
Makes sense to me. Maybe we should open an oncology truck, just go around, sling some chemo, give some second opinions on the street.
ASCO's a week away. It's not too late.
Maybe I can get a medical license in Chicago in a week.
It's like Shark Tank in here, just bouncing off ideas.
Kicking around ideas. I love this.
Okay, so I'll give you guys some credit. I'll let you buy into the company.
That's fine. Good.
Some profit shares.
Yeah.
I love it. So you work and live in New York City, like you mentioned. We found out recently a passion for climbing. So where do you go? What is that?
So yeah, I love climbing. It's great exercise. It's a nice thing to get out of the house. You meet a lot of interesting people. So Manhattan has a bunch of great indoor climbing gyms. Vital has taken over a bunch. There's also Brooklyn Boulders down in Brooklyn, as you might guess. But if you want to go outdoors, you take the Metro North, like 30 minutes to the Gunks. Beautiful outdoor climbing, great community. Even if you've never gone before, people will absolutely accept you, teach you how to do it, make sure you don't, fall, which is a thing. But yeah, highly recommended if no one's tried it before. Have you guys been climbing?
I have not. I'm not an outdoors person by nature.
They have indoor climbing now too.
Okay. It always looks interesting on TV, but maybe I'll have to give it a try.
It seems like it would be a good community.
It is. I think people get into, I don't call it a niche hobby now because a lot more people are doing it, but they just want to share it and they want to have other people enjoying it too. And like we're in careers where we want to give people more enjoyment, more quality life. We need to engage in those things too.
Yeah, for sure.
So we've talked a little bit fun, East Coast, West Coast, your climbing passions. And earlier on the tour at MJH, we talked about the why. Why do we like to work here? Why are we in this profession? So what is your why?
Yeah, I mean, that's a really good question. I kind of prefaced to that a little bit. I think that there is a certain dignity in being able to be with somebody on what might be the worst day of their lives and being able to talk them through it to make it a little easier. And even if you can't fix the problem, if you have somebody sitting in front of you with metastatic or incurable disease, you can at least give them the information and the assurance that you're going to be there, you're going to help them through this, and no matter what comes next, they're going to have an ally in that. So I find that so rewarding, and there's really nothing else that I could imagine doing. And then close to home, both of my grandparents had metastatic cancer when I was a lot younger. So originally through junior high, high school, they lived at home with us, and really had a role model in a medical oncologist who cared for them. And I remember on Christmas Eve, my grandfather was on hospice. We'd run out of morphine. He dropped what he was doing, went to a pharmacy, picked it up, came over to dispense it. Now, should oncologists be showing up at people's homes with bags of morphine? Probably not. Not the takeaway from that, but it just showed me, what somebody can do as a clinical trialist, as a compassionate human, as just a great physician. So I've always kept that in the back of my head.
That's really beautiful. It's always kind of one of my favorite things to learn about the doctors we work with is why are you in this field, and humanizes everybody a little bit more.
Yeah. And we hear that a lot because it's affected them personally. It's something that we hear quite a bit. Did you want to give a shout out to the doctor that was coming by the house? And, I would say inspired you to go into oncology. Is that fair to say?
I think he knows who he is.
Oh, okay.
So Dr. Figlin, I think he's at Cedars now.
Yep.
But yeah, absolutely. He deserves every credit, and he's done great things and is continuing to do great things. So I aspire to live up to that image, and we'll see. Maybe I'll get there one day.
No doubt. We're speaking a little bit off camera. You have a toddler and a newborn.
Yeah. Thanks for remembering.
Yeah, exactly.
Do I look like I've slept 3 hours?
You look amazing.
How are you figuring out that work-life balance? Because honestly, that's a topic that I feel like a lot of the doctors that we work with are currently going through or have gone through.
Work-life balance is very challenging, and I say that as somebody who is in clinic less than a lot of people. So a lot of my time is working on clinical trials, research, that kind of thing. But even then, with the clinical load I have, it's pretty challenging to try to set up boundaries between work and life. And I think for a lot of people in medicine and oncology in particular, there's some bleed over. I was ostensibly on paternity leave for the last month, but I didn't go into clinic. I can tell you right now, I was helping each and every one of my patients that was progressing, coming up with new plans, trying to get people medications and really pitching in. So I think part of it is having a really understanding partner who knows the importance of the role, and having a really good team behind you that can try to offset that. But I'm still figuring it out. And at the end of the day, I think people need to recognize that this is a marathon, not a sprint. Mm-hmm. They can't set themselves up for burnout. And to just keep that in mind. You can only push yourself so hard for so long. And this should be a rewarding career. So you also have to make sure you're not pushing it a little too much.
Yep. And emphasize Mother's Day. That's the big
was that a day that happened? Yeah.
We can cut that. We can cut that. It's fine. Yeah, that's it's they're the rocks that make it happen for sure.
But kind of going off that, you spoke about your team, the people in your corner, and you've previously spoke about Drs. Brown and Grewal, who you've found through social media are really your best friends. You've even spoken about you talk to them more than your own wife someday. So
yeah, most days. But what was the question?
No. So just for someone starting out in the field, what's the importance of social media, building your brand, kind of getting your name out there, getting that recognition?
Yeah, and it doesn't even have to be social media, right? I think visibility is and can be important. It all depends on what people want out of their career. So I'm somebody who is really interested in developing clinical trials, next generation of treatments, and helping to ensure that they're reaching the right providers and patients. So I think having some element of visibility, and for me that'd be things like being on X or LinkedIn, not on TikTok yet, I'm not too old for that, maybe one day. But it's so important because we can develop a cure for a certain type of cancer, but if no one knows about it, how many people is it really helping? Yeah. So I see education as a mechanism that allows us to have more reach, impact more lives. Specifically towards building a community, it's also critical, right? So Uday and Tim are two people that I would have never met if I wasn't active on social media. They weren't at my cancer center, I didn't train with them, we didn't really have mutual friends, and yet we're posting online, we message each other, we meet each other at conferences, hit it off. Now we have a podcast together. So we're doing Gut Onc Lab, which is on streaming sites near you. And we're able to dissect GI oncology in a way that I think is approachable. And it's fun because they're my friends. We go through data, and it's just a little bit easier to have other people. When I'm standing outside of a patient's room in clinic, I can text my co-fellows, but I can also text them now, especially if it's something more in their domain. Mm-hmm. So I'm grateful for the community that things like social media can bring, but it doesn't have to be through that. It can be through a variety of different mechanisms. Just plugging into your cancer center or your practice and trying to get to know the people around you can also pay dividends. I just think it's important to have people that can support you, and whether that's with questions about, hey, what was the dosing on this obscure thing that I don't remember, or how would you deal with this patient, or like, hey, do you want to just go through the data? It helps a lot. I think it makes the day a little bit more fulfilling.
Yeah, social media has really been a boom, I'd say, over the last 5 years, especially in the oncology space. We've seen kind of those social or onco-influencers, as they're referenced to now, coming more to light, and I'd put you up there as one of them.
Yeah? All right, I appreciate it. I'll take it.
Whenever I see you tweeting or posting on LinkedIn about something, I'm like, all right, this is really important. We should be focusing on this.
That's good to know. I mean, I think anyone can do it. That's one of the other takeaways. It's not like I have some skill set that I learned. I didn't do a residency for X posting. And I've only been doing it for like a year and a half, 2 years. So, the advice I'd give somebody else who's interested is just start tweeting about things, get your message out there, be honest, and it'll resonate with someone, and go from there.
No, we hear that frequently, that it's nice to have that support system with colleagues. Mm-hmm. You just jump on a quick text message and ask questions or give feedback, so that's great.
Yeah, look, I had a really hard clinical decision yesterday. I had a young patient who had toxicity and had to decide to restart them on therapy or not. And I could have gone in the room, talked to them, shared decision making to come up with something. But being able to text, a half dozen GI oncologists, hey, this is a situation, what would you do? What data are you using? Made that decision a lot easier, made that conversation a lot easier. Because really, it's not my decision, it was the patient's. Mm-hmm. But I was able to come in better informed than I otherwise would have, and I learned something from it, right? From my colleagues, from my peers. I think I'm probably going to put a tweet out about it, but we'll see that.
Love to like and repost it.
That's right. That was great. I'm glad we got a chance to know you. I know we talked a little bit off camera. This is the game section. I know you were excited about this.
All right, bring on the games. That's what I thought I was here for.
This is the game section. So we'll start with Mount Rushmore. 4 spots. Who would you put on your Mount Rushmore of oncologists?
It's tough. I think I got to go first with training. I will put Scott Kopetz on there, right? He's changing the face of VRAF V600E colon cancer. He's not a one-man army. He also has a large team behind him, but if he wasn't there, I'm not sure how much of that would have gotten done. I will put Dr. Figlin on there, right? She's somebody who inspired me to go down the path that I have gone down. The other 2 spots are harder. I don't want to just throw MD Anderson people on there because that's where I was, but they're all great. I also don't want to just put GI cancer people on there because I know my niche, I know my people. Trying to go through the list of people in my head and other malignancies is a little bit hard because I am so niche. Edward Guerin is one, so he's at UCLA, who's another mentor of mine back when I was trying to figure out which road to go down. So I did a lot of work on PD-1, PD-L1 in non-small cell lung cancer. And then the last spot, I don't know. I kind of like the idea of keeping it open. Maybe you chisel it in with somebody who's still coming up.
Okay.
So I'll give you 3.
Follow-up.
Yeah,
to follow up, we'll do a follow-up.
Let me know in the future.
Yeah.
For sure.
So going off of that, you put your Mount Rushmore, your top 3. We'll wait for the 4th one in the future. We'll follow up maybe after ASCO, we'll see. Yeah. So clinical trials. So we're going to give you 5, random order. You're not going to know which one's coming next. And you're going to have to rank them 1 to 5.
5 trials coming.
Yes.
Let's see what I can do.
So the first one we'll give you is the Breakwater trial.
Yeah, so Breakwater, I already mentioned Scott Kopetz, right? His trial, BRAF V600E, first-line metastatic colon cancer. We are now moving targeted therapy up front where we have doubled overall survival, right? for a disease where a few years ago you'd walk in the room and it'd be a very, very hard conversation because you know the survival is so poor, now you're living greater than 2 years. So really making huge strides there. I don't know the other 4, so I'm going to put this at 2 because we'll see. I don't know what's coming next, but let's put it at 2.
Okay.
Love that.
Strong right out of the gate.
That's right. RASolute 302.
I'm glad I put this at 2. Okay, cool. I still have my number 1 spot. So full data not out. There is a plenary coming up at ASCO 2026 that's going to go through this data. But we are looking at using a pan-RAS inhibitor. A lot of people said KRAS, pan-RAS inhibitor in metastatic PDAC. This looks like it has similarly changed the game in second-line pancreatic ductal adenocarcinoma. You've gone from survival measured in months, and now you're pushing out 2 years with less toxicity. But I think this goes number 1, in part because we've taken a drug and developed it for a target that was, quote, undruggable. So yeah, that whole breaking the old paradigm thing, yeah, number 1.
All right. Next one is Matterhorn.
Okay. Matterhorn, so this was a study in upper GI adenocarcinomas that basically was adding on durvalumab to our normal FLOT therapy. This is 3. It's got to be 3. You've changed. Part of what I'm thinking is how many patients are going to be affected? How many years of life are you saving if we're actually using these regimens? And everyone should be now. PD1 less than 1%. I don't know. Maybe some conversation to be had there. But in general, great study, great execution, positive study. We'll go with number 3. I really hope you have 2 terrible studies coming up. No study's terrible, but I hope you have 2 studies that are less exciting.
To be determined by you.
Yep.
Yeah, great. Okay.
We're going to ask you at the end if you would change.
Oh, no.
I want you to know all
right.
Bespoke CRC.
Bespoke, important study. Not yet fully crystallized in clinical practice. I think a lot of people are waiting for more data to come out. So Bespoke was looking at ctDNA to determine if we can tailor therapy for adjuvant treatment in colorectal. I'm going to put this at 5, not because it's not important, but more because a lot of people haven't brought it into practice yet. So in my practice, do I use ctDNA assays for adjuvant decision-making in colon cancer? Yes, as long as they're not T4 and 2 high risk. But for stage 2 patients, absolutely. I'm bringing this into the shared decision-making process.
Interesting. And then our last one, Mountaineer 03.
Okay, well, you already know what the answer to this is going to be. There's only 4 left.
Yeah.
So former mentor of mine, Raghav, worked a lot on the Mountaineer studies. So this is looking at dual therapy for HER2 positive colorectal cancer. I believe Mountaineer 03 is moving this more into the frontline setting. I think 4, maybe 3 would be the right place for this. So I don't know. I'm glad with how the order has shaken out. But important study, and we'll see as this data matures exactly what we're going to be getting out of it in terms of the benefit of the combination therapy.
Okay. So you're happy with the list that we put together?
You know what? It just happened. Let's keep it that way. I hate going back and trying to change things. So perfect order. Let's go. Move on.
Your gut instincts right there.
The next one is going to be, it's a little controversial. We keep 3, cut 3 medical journals. So we'll give you a journal. You can say whether you cut or keep it.
Okay.
Pretty much what you utilize. So first one is Nature Med.
Sure. Before I answer these, what journals are in the MGH portfolio of journals?
We'll tell you as we go.
You'll tell me? Okay, great.
Sure.
Take a look around the room.
Yeah.
Nature Med. Yeah, I've heard of Nature. That makes sense. We should keep Nature.
Okay.
Yeah.
Next one is NEJM.
Yeah. If you haven't heard of NEJM, there is an issue. You should probably consult with another local physician to go through the pros and cons of being aware of what's in NEJM. Yeah. I would say also keep. I'm going to start dumping a bunch of papers, I think.
Starting strong.
Yeah.
Annals of Oncology.
great journal, important, have published in it, and yet I feel like I haven't heard Cell yet. I think Cell is probably going to be on your list, just assuming the top 3 journals. I'm going to, Annals of Oncology, sorry. I'm going to have to slash that one.
First cut.
I hear Nature is hiring though.
A little bit of a bias, but the journal Oncology, you might be a board member on.
I am definitely a board member. Great journal, love it. It's been an honor to be a board member. Oh no.
Gonna break my heart here.
I'm sorry. I can't slash my own journal, right? If I'm a board member, yeah, keep it.
Okay.
I feel like we're twisting his arm. We should.
Yeah.
Under coercion here.
I'm not totally under duress here.
Okay.
That's okay.
All right, we're keeping it. JCO.
Out. Done. We're already at 3.
Yep, that's it. We got to.
JCO. Who reads this great trials journal with tons of new high impact information?
Not us.
No.
Out.
Nope.
And then the last one, Cancer Cell.
I knew it. I knew this was coming. Here's the problem. Cancer Cell, very nitty gritty, so many figures, so many subplots. Who has time for that, right?
Yep.
Just, write an editorial, put it into Oncology, you'll get the gist of it, totally fine. So, yeah, gone.
So you're happy with your list?
Maybe a little.
Okay.
Some could argue that Cell should be in there, but yeah, we're not. I already said we're not going back.
We're not going back.
changing
We're just
things.
running with it. I like that.
We're good.
Okay.
First
Good.
answer wins. Perfect. Now we're going to see how you feel about conferences. So we're going to do kind of like a March Madness bracket almost,
Okay.
if you're thinking. So we'll give you 2 pairs of conferences each. You'll choose, and then we'll go back to see who the winner is.
Okay.
First is ASCO GI and ESMO GI.
So as an American, I am going to say ASCO.
Yeah, that's where your heart is.
Yeah.
In America. That's
fair. I can't.
You can't.
ASCO GI, SF,
Yeah.
great.
Yep.
Although the idea of flying to ESMO, where was it, Berlin this year?
Yeah.
Sounds pretty nice.
Yeah.
But keep it ASCO GI.
Okay.
Love ASCO. Got to get on some ASCO panels. So yeah, definitely ASCO.
ASCO and AACR.
Both conferences are fantastic. They are very different, right? One is more basic science, although admittedly had a ton of groundbreaking trials presented at AACR. ASCO, though, it's coming up pretty proximal to when we're filming this.
Mm-hmm.
I'm gearing up, I'm ready to go. How else can you do 60 meetings in 3 days, right? I'm going to put ASCO on there.
Okay. The American College of Gastroenterology Annual Scientific Meeting in SITSI.
Which one of those was more of a mouthful?
They need-
I'm not going to try to repeat
They
it.
need something. Yeah, they need an acronym for that.
Yeah, SITSI.
SITSI. Okay.
Great council kind of overseeing SITSI right now, and a lot of really interesting things coming out. I have a thought that the future of oncology way down the line, we're going to be talking about curing a lot of malignancies, is going to be immunotherapy based. But recent trends, TIGIT, LAG-3, those things, they haven't panned out. So we really need the best and the brightest getting together and talking about immunotherapy. So, SITSI.
All right. And then ESMO, and another mouthful, the International Symposium of Gastrointestinal Oncology, ISGIO.
ESMO.
ESMO.
I feel like some of these are preordained, right? If I
Yeah.
can't say the conference,
Right.
it's going to be the other one.
Yeah. Next round, ASCO GI and ASCO.
Yeah, so this might be maybe a little surprising. ASCO is a fantastic conference. It is also huge. It is easy to get a little lost in. It's overwhelming. I really like ASCO GI because you have a little bit more downtime. I feel you can see people, you can talk about things. And in general, maybe there's some more groundbreaking things that are at ASCO, but I like the vibes. ASCO GI.
It's a little bit more laid back. Can't do 60 meetings in 3 days there. So.
You still can,
Or can
but
you? Yeah, I was going to say, or can you, actually?
yeah, but it's just a different quality.
Yeah.
And then we've got SITSI versus ESMO.
That's a tough one. A shout out to our European colleagues, ESMO.
All right.
Okay.
Down to last 2.
ESMO and ASCO GI.
I mean, what do you guys think? You guys go to all these conferences. I'm gonna turn it back on you guys.
I like ASCO GI, to your point. I feel like it's a little more laid back. You can get more accomplished.
Yeah.
I haven't been to either. So
Okay, next year. You got to go.
Yeah.
I'll try.
You'll come up with your ranking after that.
Yeah.
Yeah, my heart said ASCO GI.
ASCO GI.
Okay.
Okay.
We've got a nice winner there.
And we're not looking backwards. That is the winner.
No, I'm proud of that one.
We're good. All right, the next one is you have $10 to build your perfect clinical trial team.
Okay.
They're tiered, $1, $3, and $5, and you have to stay within budget.
Okay.
So for your first member of your clinical trial team, we have Robert Figlin, who you mentioned, for $5, Tim Brown for $3, and since you have a newborn at home, Miss Rachel for $1.
Wow. Normally I would say Figlin, right? He inspired me, he brought me in, but also not a GI oncologist. If I'm, putting together a trial, it's probably going to be in colorectal cancer. I'm going to go with Tim for $3.
Okay.
Staying under budget a little bit.
Yeah.
So the next one at $5 is Tanios Bakai-Saab, Udair Grewal, or $1 for Daniel Tiger.
Daniel Tiger's not in our house. I just picked him. I feel like I can't just have Gut Onc Lab have their own trials, but there's something tantalizing in that. I'll go with Tanios. I feel like we need a strong GI medical oncologist. Also, maybe he'll hear this and I can get the opportunity to meet him because I haven't met him yet. So yeah, let's go with Tanios.
Yeah, ASCO's coming up. We can set that up.
All right.
Yeah, and we will send him this. Actually.
Yes.
Sounds good.
Because we need the fourth on Mount Rushmore.
Yeah.
So we'll follow
Okay,
up on
so
that.
maybe
And this as well.
I like where this is going.
This is going. The last spot is $8. You have $2 left. So I think there's so for $5 is Yelena Janjigian, $3 is David William Wang, and $1 is Bluey.
Oh, this is easy. So we need a CRC, we need a CRA, right? So Bluey, really diligent, energetic, good learner, right? Learns lessons. I think they'd be perfect in that role. I'm going with Bluey here. Okay. Also, I only have $2 left.
$2 left. It's a dynamic team.
You got to bring the energy sometimes,
Yeah,
you know?
right.
So you are just at the beginning of your career. What's next on the horizon for you?
Yeah, being early career, in my opinion, means trying a lot of different things and kind of seeing what sticks. So developing a number of investigator-initiated studies that are now getting up and running or actively enrolling. So continuing on that path. I'm grateful Northwell has given me the time and the ability to do that and has the team to be able to do it well. So right now running IITs, aiming to deliver treatment to about 250 patients, which is great at kind of this point where I'm at. Working in a number of AI tools, like a lot of people are right now, but really trying to build out for the health system our ability to identify patients for clinical trial and also to deliver the right care at the right time to the right patient. So I got a Conquer Cancer grant to build out a system like that. And then just looking forward to the future, being more engaged with the GI oncology community in particular, and trying to spread awareness of what are these next treatments that are coming, how do we manage the toxicity, what are the little tricks or pearls that we have where we can deliver these therapies more effectively and more safely. So working on a number of different things surrounding that, but I think it's a really exciting time to be a medical oncologist. We have all this new technology coming in and we're trying to figure out how and when to slot it in to improve our patients' lives, and just kind of more of the same.
Excited to see the future for you, see what you continue working on.
Final question. Summer's here. It's almost 100 degrees out today. What's on the plan? What's on the agenda besides 60 meetings at ASCO?
It's a great question. I feel like I should be saying a vacation, but
we were hoping you would say vacation.
Yeah, no, that is not planned. Hey, look, I got a newborn at home, a month old. What am I gonna do with that?
Yep.
No, spending some time with family. I think we'll go clamming. That's always a hot ticket item for the summer.
Okay.
But just kind of doing what I'm doing. I just got back from maternity leave yesterday, so I had something of a break. It's not quite a vacation,
Not quite a
but
vacation.
no, I'm ready to get back into the swing of things.
That's a wrap on Double Blinded. Thank you, Dr. Hornstein, for joining us today. We really enjoyed this discussion.
Yeah, thanks for having me. It's been great. I know we have a few things to catch up on, maybe the 4th spot on Mount Rushmore.
Yes.
So we'll get there.
And let us know how Bluey does on your trial team.
I'll give you some updates.
Okay,
I think just from a personal level, introductions with my daughter, it's going to make a lot of headway there.
Yeah, for sure.
Yeah.
Thank you again.